One, that we respect your time and availability. This is so important to us. About 500 people registered. I'm sure they are still trying to join. I hope they join us soon. We ask that we are all on mute unless you are speaking. If you want to ask a question live, then please raise your hand and the moderator will unmute your microphone. If it is possible, and the best way is to type in the questions and comments in the Q&A box. Next. So like I've said, it's a 90-minute session. We request that all the panelists will observe allocated time during the session. And we also request that all of us be respectful of each other's opinions. We are all knowers, as you know, and we are all keepers of information. Our hashtag for today is hashtag PPFP for life. Please feel free to tag and cross-tag in your social media platforms. So our agenda today is not very long. We'll start with the opening remarks from the president if she'll have arrived. Then we have objectives of the webinar, which will be given by our moderator, Nelly. We have who will also introduce the panelists. Then we'll have a very robust panel discussion. I can assure you it will be robust. Then we'll have a short question and answer session, and we'll have a parting shot. And at the end, at the beginning, we have done a live poll. At the end, we'll also have a live poll. Then I'll move a vote of thanks at the end. So again, once again, on behalf of Hexacon, we want to welcome you to this webinar. Please feel free to learn, participate, ask questions as we go on. Thank you so much. Right now, I would like to welcome Nelly Monyasa to take it away. Nelly.
Thank you so very much, Registrar Elizabeth Oyer. My name is Nelly Mnyasi. I'm really excited to be your moderator today. I'm the Executive Director, Reproductive Health Network Kenya, and I'm a trained nurse midwife and a health system strengthening expert. And I'm really excited to be the one moderating this session that will speaking on the role of nurses in accelerating the uptake of postpartum family planning. As we all are aware, nurses play a very critical component, whether in research, clinical, community, to ensure that women and girls and even men are able to make choices and make decisions about family planning. So I'm really excited to be the one moderating this session that is joined in by very, very exciting panelists, as Elizabeth has mentioned. And these are panelists from across the region doing amazing, amazing work, and we shall be listening to them. Please feel free to engage us in the chat box, send in questions. Do not unmute unless we unmute you kindly, and we will have all our panelists, responding to your questions. So the webinar's objectives today, number one, will be highlighting regional innovations, showcasing innovative approaches developed in East Africa to enhance access to high quality postpartum family planning services, better known as PPFP. Then we will also be sharing knowledge and insights, creating a knowledge sharing platform for valuable insights from ongoing PPFP initiatives, with a primary focus on expanding top-tier PPFP services in Hexacon member countries. That's Kenya, which I proudly come from, Uganda, Tanzania, and Rwanda. So I will be taking us through just a brief bio on who our great panelists are. I don't know if our speaker has, the one providing our opening remark has joined in. If not, then we can, I can quickly provide the brief bio of our speakers. But if our Dr. Gloria Msibi is available, I welcome you to provide the opening remarks. Dr. Gloria Musibi is the president of Hexacon. Welcome on board, and is a highly experienced leader in health service delivery, strategy development, and organizational management. Her expertise spans areas such as HIV/AIDS care, maternal and child health, and women's empowerment. Dr. Glory has actively contributed to shaping policies, including reviewing the Nurses and Midwives Act and participating in negotiation workshops. Her impact extends to public sector management policies, health sector formulations, and the development of standards for quality assurance. Welcome, President.
Thank you, Nelly, once again. I'm not sure that the president has joined, but while she's still coming, because she traveled out of the country, I want to bring her apologies, but if she's in, she'll be able to interrupt me. I just want to welcome you once again to this webinar. And I want to just say two things. One about maternal health and the other one about hexagon. So in the area of maternal health, we just want to say that hexagon has really been involved in this area of maternal health. And we know and we believe that the care of women and children in any country is so important even to the indicators of any country. So we take this very seriously, and we hope that all of us in this call take this very seriously, because it really shows the direction that our country is going to. Having said that, I just want to then thank AMREF and the partners for creating this knowledge sharing platform where we can learn more about the innovations in our region, and just also be able to chart the way forward where we want to go to in the area of postpartum family planning. Secondly, regarding hexagon, I want to say hexagon is professional college of nurses and midwives in the EXA region. It has been in existence since 1990, and it is present in 16 EXA countries. So hexagon, for those who are not members, it stands for the East, Central, and Southern Africa College of Nursing. Our motto is professional excellence. So whatever we do in the region or in our countries is to promote professional excellence. So we have an headquarters in Arusha, but the rest of the countries have their national chapters. And so we have presence of national chapters in the 16 countries. Since inception, hexagon has done a lot in the region with the help of the partners. We have been involved in trainings like HIV/AIDS, like research, like leadership for change, and many others. And since those trainings started, we have been able to see those who have graduated from hexagon trainings and opportunities. They have been able to take up very, very important roles in their respective countries. And for that, we just want to thank the leadership, the past leadership of hexagon, and the present leadership is promising to continue the same. We have also been involved in policy development, as well as conferences. We have every 2 years, we have a biennial conference, and every 4 years, we have a quadrennial conference. The last conference was in Eswatini last year, and it was attended by a record number of participants, and we were able to share our experience, and particularly in sexual and reproductive health. We look forward to having the next conference in Lesotho next year, and we want to see many of you participate. And to be able to participate, we have already sent out a call for abstracts for Lesotho. Please go to hexagon.org. You'll be able to get all the details, even of how to join as a member and how to participate in our activities. Part of the agenda right now, we are working with AMREF to revamp our website And very soon, we are also starting our fellowship programs starting January. I've seen many of our potential students logged in into this call, and we welcome you. Third week of January, we have people coming in to start the fellowship programs of Hexagon. Yes, we have been late, but no, we will be able to. So again, thank you so much on behalf of Madam President. We want to welcome you to this webinar once again and hope you learn as much as I will. Thank you so much, Nelly.
Thank you so much, Madam Elizabeth, and it's really, really exciting seeing what nurses are doing in the region, contributing to, good health outcomes, and not only, working in the clinicals, but also contributing to research evidence, and that helps in strengthening, maternal outcomes. So I would want to go straight away to introduce our panelists, and I will read through their bios, the three of them, and then I will invite Dr. Ejike to start us off with the conversation. Dr. Ejike is the president, CEO, and also Community Development Foundation, chairman, management committee, Association for the Advancement of Family Planning, chair executive committee for the Association Advancement of Family Planning, civil society organization focal point for FP 2030 in Nigeria. And he's also the the chair for the Coalition for Maternal, Newborn, Child and Adolescent Health, and also accountability mechanism and current chairman board of Network of Reproductive Health Journalists. Notable contributions to the nursing fraternity, including working with the colleagues to conceptualize and push for the implementation of the midwifery service scheme in Nigeria. This scheme has largely contributed to the reduction of maternal mortality and morbidity in Nigeria by almost 40%. Good work you're doing, Dr. Ejike, and we are really excited to have you today here. Then the next is Professor Madeleine Mukeshimana, who is the Associate Professor of Nursing, College of Medicine and Health Sciences, University of Rwanda. And he is the Chair of Research Committee, Fellowship of ICN Leadership for Change Program. Notable contribution to scientific knowledge since 2014 to date includes publishing 38 peer-reviewed articles in national and international reviewed journals, 9 of which as a first author. Good work you're doing also, Professor, from Rwanda. And then finally, our next panelist is our very own sister, Prasha Auma, who is an Hexagon member and a nurse practitioner from Mbale Regional Referral Hospital in Uganda. And she has previously worked as a nurse practitioner at Sanyu Research Institute and Makerere University. So please, like we said, stay tuned. If you have questions, feel free to use our chat bot. Please don't unmute unless you've been asked to unmute, and let us really, dive deep and listen to our amazing panelists that we have today. So Dr. Ejike, could you kindly share with us, he will be talking to us. Sorry, I just want to get his session right. So could you kindly talk to us about the revolutionary journey in improving maternal and child health in Nigeria, and more importantly, on the use of postpartum family planning?
Yeah, thank you very much, Madam Moderator. I'm delighted to be here. Could I ask that they go to the next slide? Okay. Yes, Nigeria, of course, is a very big country. But before I delve into the Nigerian context, let us look at postpartum family planning from a global perspective coming to the African region. You could see that in sub-Saharan Africa, we have the highest fertility rate in the world. with a also very high unmet need for family planning. Yet, there's still lack of appropriate knowledge about the determinants, even though we know a few, for non-utilization of this method for women to be able to manage their fertility. Can we go to the next slide, please? Yes, and then we have seen some studies that have been done across Africa. And you can see the countries which show that there are three levels of things that are making women not to have family planning services. One is individual, the household, and healthcare facility. You could see reasons include a fear of side effects. In fact, in Nigeria, some years ago, Gates Foundation did a study and found out that the majority of the women decided not to have family planning because of myths and misconceptions from side effects. And of course, the gender imbalance where the men are overarchingly making decisions for the women. And then, of course, women feel that a few times when they take these family planning methods, they don't see their menses and they think that will lead to infertility. And of course, people say the abstinence is better. And then, of course, low perception of the risk of pregnancy. So these are some of the things that we have found out that was making women not to take up family planning service. Next slide, please. Now, let us also look at the specific unmet needs in terms of family planning in sub-Saharan Africa, which we are associated with health system and social demographic determinants. And then that means we have to improve on our public education and community engagement. And then, of course, do further research to be able to get out some other information. But even though we are talking about the fact that all is not good, there are still some very exciting, encouraging trends, especially a place like Egypt. And I do know that Kenya and Rwanda are also making very great strides in this particular space. Next slide, please. Now, let me now come to Nigeria in context. We can see Nigeria has the largest population in Africa, 210 million and counting. But the important thing is that you look at our fertility rate is very high, and then our maternal mortality is actually 512, not 572. I'm sorry, it's 512 per 100,000 live births. And then our CPR modern methods is as low as 12%. And then, but the most important thing, if you look at 20% of pregnancies are unwanted. And then one of the key things that we found out was that a third of all abortion complication patients come back seeking repeat abortion care within a year. So that's quite high. And then as at the time this was looked at, we found out also only 1% of women had facilitated delivery who use modern contraceptive within 6 months of delivery. So this was a very, very interesting finding. And this, go to the next slide, please. This led to us introducing in some of our sites. Then I was the country director of IPAS. I worked on with my colleagues at the time. We introduced a 3-day training on post-abortion family planning because we're already providing PAC services. And then, you know, one of the major integrants of PAC is contraceptive counseling. And then we found out that women were counseled, but they were not getting the methods. And then when we even refer them to family planning sites within the facility, they weren't going there too. And then that was what made us feel, if I was a woman and I just had an abortion complication, I was treated, why would I go anywhere instead of going home to my family? And that was what made us to train in about 557 SDPs, where we already providing post-abortion care services to make sure that they provided post-abortion family planning. Next slide, please. And then in doing so, we made sure there were 6 talk within the MVA room. So the woman didn't need to go out of the MVA room. And then there was a startling uptake of about 52%. You could imagine from 0 to 52% once the services are FP services were given to the women directly inside the MVA room. And then, of course, the providers were given additional support in terms of the log book and then client records to be kept within the facility. And then we followed up by making sure we gave them quarterly supportive supervision, joint problem solving, and then also making sure that whatever problems that they had, we were able to be part of solving it. But most importantly, we made sure that the counseling was very good so that in terms of relationship marketing, it's important to build a pattern of trusting behavior over time. And so, but we also noted a pattern that women were coming at the dead of the night, which just shows the stigmatization of family planning. Women are coming at the dead of the night into the park sites to come and receive family planning services, because we noticed that we had more family planning, post-abortion family planning clients in a particular site than post-abortion care clients. And then we used an exit interview to check out, and we found out that some women who didn't receive park service were actually coming at the dead of the night because the services are there 24 hours to receive service. That was a very interesting finding, which also goes to underscore the level stigmatization, what it does in terms of a barrier. Can I go to the next slide, please? Now, when we did an assessment, we found out that out of the women that were counseled that had PAC, about 65% of them were properly counseled, and 34% of that 65% actually received a method. And then with this, we now decided to scale, and that's why we worked with the board of the Nursing and Midwifery Council of Nigeria, first of all, to task shift post-abortion care from doctors to midwives. And then while we were doing that, we also made sure that while they were receiving PAC training at the schools of midwifery across the country, because we had now worked with the Nursing Council to include it into their curriculum. And then to make sure there is sustainability, we also made sure that we trained at the places where they produce the midwife educators. And then that has also made it to be an accreditable factor for schools of midwifery to continue to do their work. Next slide, please. Next slide. But the federal government of Nigeria has also introduced strategic priorities to increase uptake of post-abortion or postpartum family planning. And these were the strategies: increase access and then also increase demand. Let's get to the next slide. By demand creation. Next slide, please. Now, in the listing, there is co-design of intervention with women. You can't be speaking for me if I'm a woman and not talking to me. Of course, community mobilization, peer education, and then of course, empathetic communication to engender a pattern of trust in behavior. Next slide, please. Next slide, please. Now, you could see that we continued in terms of the biggest lesson is to find that PAC interventions need to be deliberate efforts, and then all FP programs should emphasize training of service providers, and then of course a reliable contraceptive distribution mechanism is also key. Next slide, please. Next slide. Now, the big takeaways on this is the fact that FP program should be given priority, and then any woman council must make sure that she gets a method. If we do not do that, it might be a big missed opportunity for a woman, because some of them, that might be the first time they are coming to a facility. If you do not get a method, we might lose that opportunity to save a life. Because of time, I'll just say you show the other slides, and then I thank you for listening to me. Can you show the next slide before we go? Hello, can you hear me?
Yes, we can hear you.
Okay, so I guess my time is up. I think it's 10 minutes I've got. I think I've actually emphasized on the most important thing. So the most important thing is the reliable contraceptive distribution, like I mentioned. because if there are no commodities, there won't be any services. Next slide, if you can. Next slide. Thank you very much for listening to me.
Thank you so much, Dr. Ejike. And most importantly, just saying, if we do not have commodities, then we will not be able to provide services. But most importantly is post-abortion care, which is very critical. We get a lot of patients with post-abortion care, and it will be important that we continue to find ways of ensuring that they do not leave our facilities without services. I will invite our next presenter, who is Sister Auma Proskovia, and she will be presenting the realities on the ground, the clinical experience, and she'll be talking to us about a service delivery perspective, best practice from Mbale Regional Referral Hospital, Uganda. Welcome on board, Sister Auma. Sister Proskovia, if you can hear me. Proskovia, if you can hear me, kindly. Meanwhile, feel free to use the question and answer session. Please send in your questions. And if, Sister Proskovia, if you are speaking, we can't hear you. Thank you so much. So please let us use the chat session so that we send in our questions. As Sister Proskovia tries to work on her network, she is experiencing network issues. In view of time, we will invite Professor Madeline. In view of time, we will invite Professor Madeline as Sister Proskovia tries to manage her network. Issues of technology and network continue to challenge us several years into getting into these things. So Professor Madeline will be sharing with us insights on faculty, research, curriculum, and curriculum integration. Welcome on board, Professor Madeline.
Thank you, Nelly. Greetings, everyone. Next slide, please. Before I briefly talk about Rwanda, I would like to share some insights from a faculty perspective. One of the strategies to increase postpartum family planning use is to integrate it into the academic institutions. To do that integrations, we need to involve the postpartum family planning into faculty expertise first, research interviews, and then curriculum development. Next, please. Next slide. So when we talk about faculty expertise, so we need to encourage the faculty to attend workshops, conferences, training programs related to postpartum family planning so that they stay updated on the latest research guideline and best practices. In that way, they're going to teach also to transfer the knowledge and skills to students. Also, another thing the faculty need to do is interdisciplinary collaboration. This postpartum family planning really need collaboration from different disciplines. For example, nurses and midwives cannot work alone to achieve the aim of postpartum family planning. We need to involve obstetrics, gynecologists, public health specialists, and also people from social sciences field. Next, please. Research, we have seen from the previous speaker how postpartum family planning is really very important, and its role also to reduce maternal and child mortality. So we need really to encourage faculty also to do more researches on postpartum family planning so that, for example, we can study about the best interventions, we can study what is working, what is not working, Also, we can get community participation. We can listen to the community so that we can generate findings or research findings that really have an impact. Also, the research can tackle the cultural and social context so that we increase the acceptance and uptake of postpartum family planning, especially in our developing countries, in our African countries. Go on, please. When I talk about curriculum integration, this is very important because if we really need to increase the uptake of postpartum family planning, we need to think about integrating its content to our curriculum so that we can start teaching, increasing the knowledge and the skills in pre-service. Because if the people leave the school with the knowledge and skills required, then we will be able to increase the uptake, to increase the use of postpartum family planning. So first of all, we can incorporate or integrate postpartum family planning content into the existing modules. For example, in the undergraduate modules of nursing and midwifery, we have such modules like reproductive health, women's health, family planning. So we can integrate the content of postpartum family planning into the existing modules. Number two, considering its importance, we can also develop a specialized course, and then we train our students. We can also train our nurses and midwives in the service. Another thing to emphasize in the academia is clinical training. You know, sometimes we forget that clinical is really much has the importance. We need to strengthen the skills. We need to strengthen the clinical training of our pre-service students, but also in the service. For example, in Rwanda, we have this task shifting where the nurses are trained offer or method of family planning. Before, we were waiting for the medical doctors and gynecologists to do so. But today, because people have the skills, nurses and midwives have the skills, it has really improved and increased the uptake. Next, please. I wanted to give some examples of the countries which have already integrated the postpartum family planning into their nursing and medical curriculums. Of course, Rwanda is among. You know, we have one big public university, and others are different private universities which teach nursing and midwifery curriculums, and also programs, and also medical programs. So all those universities today, because of the policy of Rwanda, they have now integrated the content of postpartum family planning, but also family planning in general, into their curriculums. Other countries in Africa, we have Kenya, we have Nigeria, Ethiopia, India, but this is not a exhaustive list. This is an example. And also US, UK, those are the countries that I have reviewed that have incorporated or integrated the postpartum family planning into their curriculums. Next, please. So allow me to talk a little bit about Rwanda. What is the situation? What is happening? Next. So in Rwanda, since 2012, Rwanda has really taken initiative to increase the uptake of postpartum family planning. And you know, it is an African country which people have social beliefs and have cultural beliefs. Some even were not understanding really this family planning, but Rwanda has really taken the commitment because this postpartum family planning helped to reduce the maternal and child health. So we had 5 commitments since 2012. Number one, we had a commitment to expand strategies for family planning awareness. Because of the beliefs, the social culture, and the community, Rwanda decided to increase the awareness. So nurses and midwives and the other health professionals had to do community outreach programs, educational session to teach people, to raise the awareness about family planning importance and role. To improve access also to quality family planning services. As I mentioned, you need to train the providers, nurses, midwives, gynecologists, so that they can offer quality family planning services. That also Rwanda committed to do so. Another commitment was to expand also the available contraceptive method. I mean, to have more choices. And another one is to link also evidence-based interventions, but also the policy. Rwanda took the initiative to have the policy about this postpartum family planning, not only that, by the way, in a general family planning, and to link it with the intervention. And then another commitment since 2012 was that by 2030, Rwanda will increase the domestic resources to finance the current budget about family planning interventions. Next, please. And I can really affirm that those commitments have resulted into positive change, if I may say, because actually Rwanda has increased the uptake from 53% to 64% for those who use the family planning contraceptive method. I mean, any method, any means, modern or natural, and so it increased from 53 to 64 from 2015 to 2020. While for those only who used modern contraceptives, they increased from 48% to 58%. And then for those who, the among married women, because above I'm talking about anyone, you may be married or not married, but specifically for those who are married, it increased from 47 to 58 between 2015 to 2020. Another achievement, it was that we could reduce unmet need for family planning. Unmet need, I hope you know that the person needs family planning, but she's not able to get it. That is unmet need. So Rwanda has been able to decrease that from 19% to 14%. And because of that, Rwanda has been able to decrease the maternal mortality rate from 210 per 100 live births in 2015 to only 203 per 100 live births in 2020. And we also have another commitment from 10 years, starting from 2020, we gave ourselves until 2030 to achieve more about family planning, especially postpartum family planning. Next, please. So what are the strategies? We had those commitments, as I said. We also had those achievements and success as I presented them, but we had the strategies to achieve, to put into action those commitments. So the first strategy was, first of all, to integrate the postpartum family planning with child immunization services in Rwanda. All mothers, when they give birth, they need to attend the child immunization services. So we integrated the postpartum family planning services into that service of child immunization. Number two, we really improved the counseling during the pregnancy. So we didn't want to wait until the mother has given birth, as it was before. We introduced counseling during pregnancy, during antenatal care. So Rwanda has trained many nurses and midwives about counseling, about family planning method, and now they start to do it in the antenatal care services. Another strategy was to improve providers' skills in providing a wide range of postpartum family planning method. I said so. They even did what you call task shifting, where they allowed nurses and midwives to offer some method that they were not allowed to do so before. They trained them and they increased their skills. Another strategy was also to undertake a quality improvement effort, because before people were complaining that I'm not okay, I have so many side effects, or these things are not working. So Rwanda has really taken a step to ensure the quality and also mentorship. But another strategy also that really worked is to involve males in this family planning. Next, please. So to end my brief presentation, so we can ask ourselves, what is our role in this? What can we do as nurses and midwives to improve the uptake of postpartum family planning? Because we have seen it is really important. It has a big role in reducing maternal and child mortality, you know? So what can we do as nurses and midwives? First of all, we need to strengthen the proven effective interventions in increasing uptake of postpartum family planning. Now we have listened the cases from Nigeria. We are going to listen another one from Uganda. We have listened the one from Rwanda. And I know you can read is successful, like education of the community, counseling, and so on. So we need to strengthen on that, starting from our household, our community, our neighborhood. Number two, we need to provide comprehensive education, the counseling, but we need to sometimes we miss, and we take all people in general, but people have specific individual needs. So we need to tackle those ones. Another thing is to ensure safe and timely initiation of the chosen method. You know, sometimes a mother chooses, a woman chooses something to use a method, and then we start to say, it is not available, you can use this one. No, we need really to try to offer that on timely if the person has chosen that one. Conduct follow-up appointment is very important, especially in the community. We need to do educational session in the community to reduce the myths and misconceptions about family planning. We need also to encourage involvement of male partners. Please start from the friends, start from the neighborhood, start from the wherever you are in the community to make sure that the male partners understand their role in this postpartum family planning. And also try wherever you are working from to contribute to the generation of data, you know, because if we participate in the research, in generating the data, we are really creating, how can I say, we are participating in showing what is working, what is not working, what can we do or to improve that and that. So that's what I can say to end my brief presentation. And I thank you so much for your kind attention. Thank you.
Thank you so much, Prof. I think your presentation was quite insightful. And one of the things that I'm just hearing is countries that are already integrating PPFP into their curriculum. And this is really critical because a lot of times is the capacity of healthcare providers to provide some of these services. And it's a challenge you've also alluded to. So really, it will be important during their training school, then they're able to get this information. By the time they qualify, they are in a better place to provide these services. Something else that I really liked from your presentation is task shifting, because healthcare workers need to support each other, and there's just so much that, you know, healthcare providers can support each other if well capacitated. Then integration of PPFP with CWC, really ensuring that there's no missed opportunity when it comes to women getting these services. Then intercadre collaboration, and I think this speaks to task shifting and also just ensuring that the nurses and midwives are working very closely with the other healthcare cadres to ensure that we all have the capacity to provide these services. Thank you so much, Prof. And questions are trickling in. Kindly continue sending in your questions. We should be able to start sharing those questions and having the panelists respond to them immediately. We have the presentation from Mbale Regional Referral Hospital Med. Welcome, Proskovia or George, if you are standing in for her.
No, hello. Yes, this is Proskovia from Mbale Regional Referral Hospital. Nelly, are you able to hear me?
Yes, you're loud and clear. Please proceed.
Yes, I'm going to present postpartum family planning as a hospital. And next slide. That's what is family planning, and you know, family planning is a choice. It is a couple's choice
Sister Proscovia, we can't.
How many children to have, when to start, and when to stop, and how many children to have, and what interval. And as a country, has tried to avoid like radio talks, advertisements, and related, and advantages of family planning, and not like in the facilities, the speakers can understand what is passed to them. Then also train health workers on how to give the methods and treat complications which arise due to family planning methods. And in the training, like you realize that midwives are trained from the lower cadre, post-abortive care. They are taught how to do
Can't hear you properly.
And immediately give the. Yes, please.
We cannot hear you properly.
Oh, sorry. So in this, you realize that the incorporative and the other services, like in YCC, when the mothers come to, like immediately when they come to for delivery, meaning for immunization postpartum, like at 1.5 months, they also incorporate family planning in the services, so that it is at reach that when she comes for one service, she can also get the other. And also when the mother comes for delivery, actually they are told from antenatal. When they are taught from antenatal to prepare them for the family planning method immediately after delivery, as they come to during labor, they can also be given the family planning method. Even in post-abortal care, as they come for post-abortal care, they can also be given the family planning method. Next. Next slide. Yes, so family planning has not been achieved as expected of the region and the country, whereby we have a family planning which is achieved by less than by 50%, which is not good for the country, even for the region itself, which means that there is a low intake of postpartum family planning method. So if family planning was to be taken serious for both our mothers and the families, some maternal deaths would have been reduced. Like, for example, if immediate intervals of conceiving, these mothers actually would have avoided all that. And remember, these mothers, the quicker you deliver, the more children you have, you can still develop to PPH. And we have seen PPH is one of the most leading cause of maternal deaths in our, actually, especially in Uganda. And if these mothers would have large intervals, prolonged intervals to produce from one child to another, actually would have avoided the maternal death. Then most women deliver at the health facilities where these methods can be given at a free cost. As in the country, it has tried its best to avail all these methods to these mothers at a free cost. And as low as our facilities as level 3, where mothers are delivered and admitted, that's how the country has gone as far as that, to provide from level 3 up to the regional or national regional referral hospitals. So next. Next slide. Okay. So the key observations here, we look at the positives, is there's continuous health education of mothers, as this can be group during antenatal, can also be during when they're admitted in the ward to be served. They can still, the midwives and the doctors continue telling them methods about family planning. And even the risky mothers, they keep telling them, even if they're going for cesarean section, for example, they still tell them that please, they educate them about family planning. Then also adolescent critical approaches. So this is the friendly approaches whereby they teach adolescents about family planning. As they come for other services, they get these family planning services. Then also with cost-free services for the entire country. Every mother, every man can go for the method at a free cost. It's not charged. Then immediate provision of methods, whereby in Uganda, like in Mbale Regional Referral Hospital, methods are got, most of the methods can be got in labor ward. The mother can say, yes, you have told me about this method, but I want Jadel immediately after the birth of the baby, and she's given. And we've even observed this, they've taken as far as to theater, and even the mother says, I want an IUD. So when they do a cesarean section after the delivery of the placenta, before the doctor repairs the uterus, the method is provided to this mother. So which is also a key and it's very important. And that's how we have managed to give these methods to those who have chosen to take the methods. Even in PAC services, a mother comes with a miscarriage, you tell her, no, you need to have also a rest for this uterus and for your body itself can take a method. Some of them are able to take the method within at the cost, zero cost, and also within the services at the same time. Next. Okay. Comprehensive health care workers engagement, whereby they teach, and all the midwives are taught. They even through in-service training, they keep on refreshing through CMEs, and they really give these health workers the knowledge, and they update them to help this mother get the services. Then accessible services, women actively seek services from their village health team. That is whereby the facilities, the government, the policies has taken as far as the village health teams. These are not rural trained health workers, but these are leaders who can give some information pertaining the health related to family planning. They take them for a small training that they can also dispense, and they can also refer mothers in case of anything. And by health facilities indicating the protective approach to reproductive health management. Then also maternal adoption of contraceptive methods. Some others actively accept the methods. Of course, not all of them will accept the method, but some actively accept the method, and even they engage their friends. They even be the peer group tellers. They even educate their colleagues that this is what has been happening. And they even tell their colleagues that the advantages why they take these methods, and they also give them the advantages of taking the family planning methods. Next. Yeah, the prompt communication for issues resolution. Women productively engage with health workers to address any concerns or issues related to family planning, focusing effective communication channels. These mothers, actually, they give them the toll-free lines. They give them a health workers providers number, so that when she reaches home and she gets something she's not pleasant with, she's able to call and consult at this and this has happened to me. How do I go about it? And the client is either told to come back immediately, or they will tell her what to do pertaining the side effects. Then the post-cesarean section is strategy. This one, women who undergo cesarean sections are often pregnancy with a fresh scar, the more of complications that she gets. So we always have the method why they think they will not resume sexual intercourse. So as a culture in Uganda, some mothers deliver and they go to their home where she's born. So she thinks she will not stay around with her husband. She will not resume her sexual intercourse immediately. She can stay there for 2-3 months, and before she resumes to resettle with her husband. So this is a challenge. So they tend not to accept the methods immediately. Then also they think of scars after surgery, and most of them think maybe there will be an effect when they get the same time the announcing the scar and the family planning is in situ. So they tend to reject the family planning methods immediately. They'll say, no, I'll come back after a certain period of time when I'm very sure that I've healed well. Then also they want their partners. They also want their periods to first come back, resume. And they think that most of them think that when the periods have not yet resumed, and have inserted the family planning or they've got this family planning method, they'll think they will never undergo any menstrual cycle again because of the period. So they prefer having the periods first, then they have the family planning later. So which means they tend to get the family planning method after 2 months of delivery, which is also not good as the community and the health workers. And also the knowledge gap among some of the health workers, and some of the health workers tend to get just scared or they fear to insert, despite of the fact that they've got the concept, they're being taught, the in-service training has gone in, they still have that phobia of providing immediate postpartum method to the mothers. Then also no time to take the client through as due to the workload. And this is seen when, like in Mbaro General Referral Hospital, we tend to have over 8 to 1,000 deliveries per month. So which means in average, you can deliver like 25 mothers per day. So in this, and a ratio of like 3-4 midwives running all the shifts for 24 hours. So sincerely, if you incorporate again a lot of information about family planning and putting the method in, and the mother is also there in the labor ward and they have a long queue, they tend to think they don't have enough time to talk in details. You know, when you're giving somebody a method, you need to take somebody thoroughly to understand a method, to overcome the myth about their family planning. So you need to have enough time to talk to these mothers. And yet the other mothers yelling in labor ward. So sometimes the health workers tend to have limited time to talk to these mothers. Now, how can we excel as midwives? What can we do? We have tried to, through health education and male engagement, to create demand for postpartum family planning. As they come in labor ward, keep on encouraging, and antenatal care, we keep on encouraging them. We talk to them, and actually some of the men adapt it. They accept and tell their wives no. They tell their wives, they encourage their wives to go with the method. Then also they ensure all methods are needed, are available, whereby you also incorporated from the family planning unit, that if labor ward or gyne ward, wherever they do postnatal care, if they don't have the methods, they can still with mothers, you first create the rapport with them and make them comfortable, and confidentiality is ensured. So that's why these mothers tend to take, because there is also a myth in culture that if a mother takes a family planning method, she might deliver an abnormal baby, the next baby. So what they tend to do, you have to give them privacy, so that when she gets her method, no one can know, like a neighbor or colleague from the hospital, maybe a relative, if she doesn't want to disclose to them. Then and through giving the information and then proper referral. There are other methods like tubligation, when the doctor is not there and the client needs the method. You as a midwife, we try our best to call. We call the doctors that, please, let's give this method to this mother. The mother's decided to have BTL and the method is done. So proper referral. So in case of like a complication the mother develops, ensure that this mother is handed over to the proper person who can manage that complication. Like, for example, we refer them to the nearby consultants or the medical officers or a senior midwife who has known all about these complications. So that's what we do by proper referral. Then also proper management of any problem of complication or related to family planning. And also side effects, we manage them appropriately. Next. Wow. So that's all what about, which was concerning about family planning methods. And as midwives in Bioregional Referral Hospital, that's how we have managed to accelerate the family planning methods to them. And you realize in this, even in post-abortal care, we used not to have the services in situ where we do pack. But recently, from June this year up to date, actually the methods in the pack room that when a mother needs it, because if you delay to give this mother at a point of acceptance, she can change her mind. So immediately when the mother you're going to take her for MVA, you talk about family planning, then she'll tell you that I want this method. So that when she consents for the evacuation, it's also she consents for the family planning methods at a go. Then immediately you give her the methods, and that's how we have overcome all these. Though the number is still low. Back to you, Nelly.
Thank you. Thank you so much, Sister Proskovia. We are really excited that you are able to call in and, we've been able to really hear the great work that you're doing. And one thing that really came out was the adolescent-centric approach. A lot of times when we're thinking about innovations approach, we forget the population that forms the greatest percentage, and that is the adolescent and youth. And I would really want to hear more, it will be good for us to discuss more in terms of how do we ensure that we are not leaving the adolescent behind. When we look at indicators on teen pregnancies, when we look at the indicators at school dropouts, it's a lot of teens that have engaged in unprotected sex, and because of the socio-cultural context, they are not able to access some of these services. So really it will be good for us as we talk about the great work we are doing, being intentional in ensuring that we are not leaving adolescent and youth out of our interventions. Thank you so much. And we are now getting into the session of question and answer. I've seen a lot of questions have come in, and I'm seeing a lot of questions going to Rwanda. I just want each one of us to have a session to respond. And we will start by the first question that came in from Stembile, who asked that, what is the role of community healthcare workers when it comes to home delivery? And I think this we can respond to it as we answer the other questions. So Prof, I'll start with you because I realize that a lot of questions are coming to you, and I see that you've also tried to respond to them. The question of, could you specifically talk about contraceptive acceptance rates in the postpartum period from immediate? You can talk about that, and also talk about I had seen a question for Rwanda also. I wanted you to respond to all. Yeah, so there's the good job. I note that there's only 10% improvement in all indicators over 5 years, despite all the good strategies and work. Kindly share with us the challenges and what you're doing to overcome that can be replicated somewhere. So if we can start with you, Prof, if you can answer that question of challenges and the first question on postpartum period, essentially, what are the contraceptives acceptance rates in Rwanda?
Thank you so much. To answer the first question about acceptance, I think I presented about it. From Demographic Health Survey 2019 and 2020, it shows that the acceptance rate or the use has increased from 20% to 54%. That is postpartum family planning. So I can stay from there, or I can give other 2 examples of other studies done. One was done in 2018, it's a qualitative study, and it was looking about acceptance rate. So among 28 participants, because it was qualitative, 19 accepted the postpartum family planning immediate, and only 9 declined. And also another one, it was descriptive, quantitative. It was done in 2019, where it shows that 47%, the participants were 105 participants. So 47% accepted the immediate postpartum family planning. However, we can stick on that from demographic health survey that indicate that we have increased from 20% to 54%. The second question asked about the challenges. First, I don't think we have only increased 10%, because as you see, from 20 to 54, it is not only 10. So you can increase a little bit. But we still have challenges, as you said. And among those challenges, the first one in Rwanda we are facing, I think it's common for African countries, it's social and cultural beliefs. You know, we are in African country, and many people in the community believe that having many more children is better. It's a prosperous family. And also the culture, the men dominate. It's a patriarchal culture, if I may say. So most of the time, women need family planning, but men say no, because it's a patriarchal, and they believe that having more children is better. So we really face that every day, every time. Another one is religious beliefs. You know, we are an African country, and many people have religious beliefs. Sometimes you can't change those beliefs. And another one is the beliefs that people, even many, they believe that they cannot get pregnant after giving birth before the menses resume. That is really personal beliefs, which people are still having. However, people can get pregnant before you see the menses. And most people are giving birth for the first time, do not really uptake the family planning. So what can be done and duplicated in other countries? For religious beliefs, I don't think sometimes you can't change, but we need to strengthen education, community education, and awareness to improve what people know, so that we can increase the awareness about the role of family planning, how this works, and also try to challenge the myths and beliefs about social and culture. Thank you so much, Nelly.
Thank you so much, Prof, for that. Sister Proskovia, if you can hear me, and we are running short of time, could you kindly comment on IUCD soon after delivery, and any comments regarding expulsion with postpartum bleeding? If you can hear me, could you comment on that? And also the role of community health workers in home delivery. Those two questions, please.
Actually, the role of community health workers in deliveries. And for this, actually, they keep on encouraging them. What for them they do refer to the qualified personnel. For them, they identify the mother and they hand over to the health worker or to the midwife. That's mostly what they do. And in case of any complication, they also try to help educate them and refer them. Then there was also another that most doctors actually fear to insert this method. Not every mother, not every person is wishing. That's why I said at first, excuse me, that some people still have phobia. So we keep on encouraging them. And even the pressure from the mothers gives them to take a risk, to give them the method, not actually a risk, give them the method. The mother will tell you, I want this method and I want to go with it. So as you're a health worker, you cannot deny a mother a right to go with this. Because in case of anything, she gets either pregnant, she'll still blame you. Then how you do with the PPH after delivery? Actually, not all mothers bleed. What we do, we give the method. Then when a mother develops a PPH, and on the file it's written that the mother has got an IUD, what they do, they re-examine this mother. If the IUD has moved, they reinsert the method. If if it has not moved, the mother remains with the method. Not all mothers bleed because of the IUD. IUD has no anything concerning with PPH. Actually, for it does not even cause PPH. If the mother has got PPH due to a uterine atony, that would have been a mother's cause, not the method's cause. And somebody asked for the workload, that how have we managed? And this what we do in labor. If a mother missed the counseling before delivery from antenatal, you the midwives, you can keep on as engaging her as delivery as you're giving, if you're the first golden hour to the mother, to the baby, you also bring in some more information about family planning. And when this mother is taken to postnatal ward, this mother is not discharged without being cancelled. She can either not get immediately from labor ward, but she can still get the method from postnatal ward before discharge. And we discharge them after 24 hours of delivery. Those who have delivered normally. Those who have delivered cesarean section, as the doctor does the ward round, and when the midwife is also giving treatment, sometimes they can prompt them to about family planning method. I submit.
Thank you. Thank you so much, Sister Proskovia. There was a question for Nigeria. However, I've seen Dr. Ejike has already responded to it. Let's continue engaging on the chat. Please, for the panelists, the questions that have not been responded to, please feel free to respond. Before I hand over to George, I would want to say that in Kenya, I have seen us being intentional in engaging religious leaders as champions for family planning, and they have contributed to our good CPRs and just ensuring that they deal with the cultural, the religious barriers to accessing contraceptives in the country. Maybe this is something we can also borrow from our different countries that we come from. And more importantly, engaging also in community dialogues where we bring on board different stakeholders and opinion leaders from the communities and bring nurses as midwives, as experts to, demystify myths and misconceptions around family planning. Thank you so much. It was really nice moderating this session and having the great panelists. At this time, I want to hand it over to George Capio. Thanks.
Thank you so much, Nelly, for the wonderful moderation. Thank you, everyone, for keeping it locked. At this point in time, I want us to move to the session of additional resources that we might find of use in our day-to-day activities, in our programs where we work, in facilities where we work, in policy decision-making bodies and spaces where we work. We have an additional resource in the name of FP Insight. This is a very resourceful tool that every other person in the space of SRH family planning would find very interesting and very useful, because it would help you unlock and personalize a few things that you'd want to do in the space of reproductive health. So this is one of the products of Knowledge Success Program. And I would urge that after this or during this session, you'll be able to log into the website that I've provided in that slide, so that you're able to sign up for this particular tool. It is very effective, it is efficient. You can use it even in your personal mobile, so that you're able to constantly get engaged, constantly get informed, and constantly get more ideas that are coming in the field of SRS. So what are the capabilities of this tool if you have it FP Insight? So there are key things that this tool will be able to help you do. It's a resource discovery and curation tool. So while many of us have had problems getting resources or trying to find out resources related to family planning over SRS, this tool here is your answer. It's going to give you quick access to various tools. It also enables you to also curate your own tools that you're able to, your own resources that you're able to use, and once you have an account within it, then you are good to go. It's built by and is for FPRH professionals and the enthusiasts who are working in this space. It's one place to save all your favorite resources, because again, some of us are those in the academia, those who are still doing their papers in the academia, especially in the area of SRH, you are able to save all your favorite resources and refer to them. And then others can use it to discover and get inspired. When you log into this particular tool, you'll be able to discover a lot of good things that our colleagues in this space are doing, and we are able to learn from that. So if we use this, if you use this tool continuously, we are together contributing to a body of knowledge that will benefit the whole FPRH professional community or every other person that is working in the FPRH space. So if you click into that particular website that is www.fpinsight.org, it will give into a window that gives you an opportunity to be able to sign up. So for those of us attending this webinar who have not signed into FP Insight, please take this opportunity to log into that link, that website that I've indicated down there, and sign up to FP Insight. Once you've signed up, you'll be able to get access to very, very, very many quick, timely information. You'll save what you need. You get inspired by what others are doing, and you are able to really get a feel of what is happening in the FPRH space. So I urge all of us to be able to sign up. I believe that out of this, we'll be able to, for some of us, for those of us who are not signed into this, please take this advantage and sign up into it, because it's a one in a lifetime opportunity to beef up your resources in the FPRH space, but also interact with people in this space who are very beneficial. Thank you so much. So at this point in time, we are moving to the next space. As we wait for the poll, we can invite, okay, the poll is there. Thank you so much. So we are doing the poll, and please, as you look at what the question, that we have two questions for the poll. So just log into, just log into your phone or whichever more media you're using to access this webinar. And the first question is, overall, how would you rate the quality of this webinar? Is it excellent, very good, good, fair, poor? And then in the next question, how well did the webinar meet your expectation? How was it? The first question, how would you rate the quality of this webinar? Then second question, how well did the webinar meet your expectation? And what was it? Please keep your votes coming in. We are very interested in getting this because it will help us improve quality of subsequent webinars that we're having in series. After this, we'll be able to share with you just a heads up to look out on the upcoming webinars that are coming up in next year. So keep your votes coming, because this is very important for us. It's going to help us improve on the next webinar series.
Hello, George. Sorry if I can interrupt. We actually have 9 questions for the poll that you see in your screen right now. So yes, just everyone, if you could kindly take a few moments to go through each one to answer. And as George has mentioned, it would be very helpful for us to see the rating for how well this webinar went, also so we can improve for our subsequent engagements with you as well. Thank you very much.
Thank you very much. So the third one is, was webinar too long, too short, or about right? The fourth one, how helpful was the content presented at this webinar? The fifth one, how engaging were the speakers at this webinar? The sixth one, how could future webinars be improved? Select that apply. And then the last one, the seventh one is, how likely are you to share the recording of this webinar with colleagues, clients, and friends? Keep your comments coming. keep your comments coming. We are having about two more minutes to go. We are at 35 out of 80. We are many. Let's keep our votes coming, our comments coming. It's very important for us. Less than a minute to go.
George, some people are asking where the questions. From the messages, some people are asking they can't find the questions.
Maybe for, I see, yes, there's one person who can't see, Opello. It was a poll launched by Zoom, so it's an automatic pop-up that you should have gotten. And maybe besides Opello, is there anyone else who's not able to see the poll? We have launched a post-webinar poll that should be showing on all of your screens. It should come as a pop-up. In any case, we're still happy to receive written feedback in the chat. So maybe please kindly share your thoughts on chat and we will, the pop-up is not popping. Sorry, Jacinta. Maybe you can just give your few comments and rating of how we did today on, the quality of the webinar and if it met your expectations, what you thought about the length and content presented, and if you found it engaging, and if you have any comments on how this webinar could be improved. Let us know if you would share this webinar with friends and what other topics you would like to see from us. Apologies for those that weren't able to receive the poll automatically. But George, maybe with that and due to time, we can also move on and host,
okay.
Yeah,
Okay.
as well.
So thank you very much for participating in the poll. I would invite Elizabeth to give a vote of thanks.
Thank you, George. Thank you, everyone. I just want to say thank you to God for this opportunity to have this first among many webinars that we will have next year. Special thanks to AMREF for this knowledge sharing platform. We really appreciate, we don't take it for granted. We want to thank Nelly for being a very professional moderator. Now we know where to look for moderators. Excellent. The speakers were spectacular. Thank you. We got the most important innovations that are happening across the region, and we were being able to learn. And so the question in our minds is that what are we doing in our specific areas? There could be more that we are doing that we need to share, but whatever that people have shared, our speakers have shared what it is that we can learn from them and put into practice. I want to sincerely thank the participants. They are from 12 countries that have counted. Maybe I've missed some. If I have, just put in the chat. I've Seychelles, Uganda, South Africa, Kenya, Zimbabwe, Botswana, Malawi, Eswatini, Tanzania, Nigeria, Laos, and India. We have gone up to India. We also want to specifically also thank a former president of Hexacon. I saw her in the audience, Madam Kio from Botswana. Thank you for sparing your time to come. We also had the former VP for Hexacon, Rose Patricia Oluoch from Kenya. I've seen several NRs. Thank you so much for attending. And I've seen partners like the PIGO. So thank you so much for coming. Finally, I want to thank the Secretariat in Arusha for a job well done. Please continue as we engage AMREF and other partners in the near future. Thank you. Back to you, George.
Thank you so much, Elizabeth. At this point, I want just to also conclude by looking at giving a shout out in terms of what we need to look for next. Hexacon is doing a series of a webinar series. This is one of the many webinars that Hexacon is going to have frequently. Coming up hot on heels of this is a webinar in January, and the date will be communicated soon. The topic that we are looking to have a thorough discussion on in January will be role of nurses and midwives in enhancing quality of adolescent sexual and reproductive health, ASRH. After January, in Feb, we'll also have a webinar that will be talking about promoting mental health to nurse practitioners, nurse and midwife practitioners. And then come March, we'll be able to have another webinar on integrating mental health into MCH and SRH. So we'll be on the lookout for calls for calls of this particular series that are coming up. And I welcome you all to continue engaging and continue participating. Thank you so much.
Thank you, everyone.